Hi everyone, this is Dr. Ashwini, and welcome to the Holistic GP podcast. Today we have Dr. Warwick Bishop. He's a three-time international best-selling author and a cardiologist with special interest in cardiovascular disease prevention by incorporating imaging, lipids, and lifestyle. So let's get in today and speak to Dr. Warwick. And welcome to the show, Dr. Warwick. How are you? How are you doing?
I'm very well, thank you, Ashwini. Thank you for having me on.
Great. So I think today I've got a lot to speak to you. I saw your work you do, and it's very impressive, especially in the preventive heart arena. And I think as a holistic GP, that's what I actually want to get into mainly. Can you first give us a bit about yourself and how did you get into this field and what made you feel so passionate about preventive cardiovascular health?
3 years ago, around about 2005, going to work on a weekend day, there happened progress, and I saw a commotion by the side of the road. I, being a doctor, thought I should stop and see if I could help. It turned out a man, one of the cardiac arrest, and was literally dead by the roadside. There was an ambulance and attendant from the Fun Run helping. Together we were able to get his heart beating again. He was put in the back of the ambulance, taken to the local hospital, received a anterior descending artery. His life was saved. Mother of 3 children. When I worked, because I happened to get a mention, only to have one of my secretaries point out I'd seen the very same man within the previous 2 years. Dr. Ashwini, I put a shiver down my spine because I looked at my notes. I'd done everything right for him. 2003, everything guidelines at the time, and had only to be standing over literally his dead body some 2 years later. Made me realise that treadmill testing and on the outside is not good enough. And from there, I really opened my mind to on the horizon what can we do better. And it makes sense.
I mean, I think that's really important. Sometimes, we think we have done all the things based on guidelines. But from then, Dr. Warwick, what were your how did you change your way of practice, and what are the current things you feel are important for us to assess a cardiovascular health?
So, one of the most significant changes I've made, and one of the things that I've actually led here in Tasmania, is imaging the arteries directly. And the process for that is coronary artery calcium score together, a website to allow people, if appropriate, to organise that centre in Australia. That's virtualheartcheck.au. Now, that imaging is incredibly important because, as you know from your own experience, sometimes we see people. And this fun runner, I can tell you, he was only just 50 years of age. He did extreme treadmill test. A couple of years later, had a heart attack. Now, if you think about it, this was a man who put on his shoes expecting to run a 10-kilometre fun run. He didn't feel any risk at all. And you know that coronary artery disease can lead to sudden cardiac death in people who are without any symptoms, and that's because in the pipes, the cholesterol can build up in the pipes. It can rupture and then cause or a sudden narrowing. Up until that point, it's silent. So my real passion has become letting people can image arteries and really get a on the health of someone's arteries well before a problem occurs.
Yeah, that's really important. Now, from your experience, like you said, everything was good for him. Someone with a normal cholesterol markers, do they still have a risk of build-up in the arteries?
Dr. Ashwini, that's a great question and something I confront all the time. A lot of my practice is now preventative, and so I get many people who get their local doctor asking, should we be treating this person's cholesterol, yes or no? Well, the conversation is a really simple one. I see people with really high cholesterol and terrible arteries, but I also see people with really high cholesterol and clear arteries. And I also average cholesterol and terrible arteries, average cholesterol and clear arteries. And to be honest, even though I've been doing this for 20 years, I cannot guess who's who, because occurring at a molecular, cellular, and anatomical area or region within the arteries is far more complicated than something as simple as what's your cholesterol.
And I think that's really important. Like what I think is it's very personalized. It's not one bill fit all, and that's what I get really worried, because now there's a lot of negative image for statin for some reason. I mean, not everyone needs it, but a certain group of patients really benefit from it, and and that's what I try to tell them. We have to look at everyone individually. So, what's your thoughts on that? Why has statin got such a bad coverage in recent years?
Yeah, they've got a bit of a bad rap in social media to a large degree, and there are some interests and push the barrow. The biggest large degree is exactly what I said. I see people with high cholesterol, bad good arteries, low cholesterol, bad arteries, low cholesterol, good arteries. So the people who are proponents of negative comments about statins probably say, oh, cholesterol's not important because you can't predict who's going to have a problem based on cholesterol. And to a degree, I actually agree with that premise. Because trying to predict who's got a problem just based on their cholesterol, I've just explained, is quite, well, it's fraught with problems, because we don't know how an individual is going to put cholesterol in their arteries, whether high or low cholesterol make a difference for them. The bit of the story negative proponents for statin and the cholesterol stories don't share is this. We've got over 25 years of absolutely irrefutable, clear-cut, randomized controlled data that tells us if we find someone with bad arteries, as evidenced by stroke, heart attack, or stenting, so these are people that have got build-up of plaque in their arteries, their cholesterol is high or low, our data supports lowering that cholesterol to reduce future risk for that. So the simple answer, Dr. Ash, and for the people listening, is if you've got build-up of cholesterol in your arteries, lowering cholesterol for you, if you're high risk, will be beneficial. If you've got nothing in your arteries, whether your cholesterol's high or low, then being on statin or any cholesterol lowering medication, or even aspirin for that matter, is probably not going to be beneficial for you.
Yeah, and I think apart from that, there's a lot of research now. It's not just cholesterol that's the problem. It's more of the glucose, high sugar, high fructose, high carbs. That's also a problem in cardiovascular health. What do you feel about that, Dr. Warwick?
Look, I think it's a multifactorial problem, and as soon as we try to dumb it down, and I think it's important to look at the whole process. And the analogy I often use, Dr. Ashwani, with my patients is a car, driving our car. Now, if we drive sensibly and we make sure we top up the water, fuel, we wear a seat, check the air pressure, they're all really, really good things to do. And they reduce your accident. But if you don't look under the bonnet, if you don't get your mechanic to regularly service that vehicle, you don't know what's happening underneath the bonnet. Could the about to fail? Could the brake pads be about to fail? Could it be leaking oil that you're not aware of? So there are so many things that can go wrong and lead to a motor vehicle accident. We would be naive to think that we don't have multiple factors that impact our heart health. So what you're is exactly on the money. We do need to drive our car safely. We need to make sure we keep our carbs down, our fructose, reduce inflammation where we can, keep our triglycerides down, X, not get stressed, watch our blood pressure, not smoke, all these really important things when we drive our car, but that I really want to get across to the people listening today. And my message is drive your car well, but you've got to look under the bonnet as well. You've got to do that maintenance. And the way to do it is for men over 50 years of age to be considering getting a scan on their heart, women over 60 years of age to consider getting a scan for their heart. Until we look, we don't know what that individual's propensity, what that bit of putting plaque in their arteries is.
Thank you. I think that's really good information for our listeners there. But as when you spoke about that, I just thought, from a cardiologist perspective, is there a prevalence in the gender of the patient and the outcome or the severity of the disease, or is it equal in male and female? What's your experience?
Yes, so men and women do present differently, and women in general terms present about better than men, and that's because they go through menopause and are up until that point to a large degree protected by the female hormone estrogens.
Estrogen, yeah.
So, a large degree, women who are at risk will recognise those risks about a decade after their twin brother. Often we sort of see that women might present slightly. They don't have as characteristic, if you like, Hollywood type chest pain and heart attack events. They have maybe fatigue, maybe congestion, maybe shortness of breath. Or having said that, they still do and can classical symptoms, if you like. The women may also present with slightly different symptoms, and that's important for this to be aware of those subtle that may need to be evaluated.
So from that, if you're saying CT calcium score is a good test to be doing, if someone has 0 calcium score and their cholesterol levels are good, should we be putting them on a 5-year screening, or do you think that's too early? We should be putting it a bit later. What's your view on managing imaging appropriately?
Yeah, look, that's a really Dr. Ashwani, and to come back, we don't want to be investigating people wrongly. Over-investigation is as big a sin as under-investigation. And in this particular case, the imaging $100, so you don't want to be wasting people's money. It's associated with a very small radiation dose. Yes, you don't want to overexpose people. So it's a question. The current National Heart Foundation of Australia position paper, and I was one of the co-authors of this, would recommend in the setting of a 0 calcium score, repeat imaging should be considered at 5 years. And as I said, as we look at who should be imaged, which is also a really important question, it's generally that intermediate risk group. That for your listeners, people who are really low risk, probably don't need to do much about them, just see them regularly. People who are really high risk, of course, they should probably be on therapy. GP should be looking after their blood pressure, their diabetes or their pre-diabetes, etc., etc. But the people who are the tricky bit are the intermediate risk people. And imaging these people's hearts allows us to re-stratify those people in risk, in which case they should be on therapy, or truly low risk, in which case see them in 5 years. It's a fantastic tool for helping us discriminate intermediate risk category. And that intermediate risk category is comes about for men, mainly at 50 odd years of 60 years of age. So it's a pretty easy thing to remember.
And CT calcium score versus CT angio, when do we decide which is a superior test for that individual? If they have a 0 CT calcium score, are we happy leaving at that? Or if we feel, you know what, if there is higher risk, should we then be referring to a cardiologist for a CT angio? Or how should we be managing that two different imaging modalities out there?
Dr. Ashwani, that's a very technical question. And obviously research or have good experience in the field. It's a really a very pertinent question. If I can just explain for the people listening to try and help them understand what a coronary calcium score does not contrast whatsoever. You literally walk in, have a shot, a CT scanner. All the scan will pick up is presence of calcification. Now, calcification is a sensitive presence of build-up of plaque. My own patients, I call it rust in the pipes, but that calcium is a very sensitive indicator of what's in the arteries. Plus, it gives us an idea of whether there's a little bit, a lot, or something in between. What Dr. Ashwani asked is whether we should be injecting contrast to outline the arteries in even more detail, because by doing that, we can sometimes pick up plaque that's fatty plaque that hasn't yet had time to develop calcification. And this could be really, really important. The answer to your question from a practical perspective is that all our data is primary preventative asymptomatic setting. And that means for people who have no symptoms whatsoever, a calcium score is an incredibly robust finding and should give us 5 years reassurance that the chance of a heart attack is extremely small. You can never say never, and in no case in medicine do we ever say never. If we inject contrast, it adds a couple of things. It adds increased cost. It adds radiation dose. But importantly, it adds a very small risk of severe allergic reaction to the contrast. So doing that routinely on people who have no symptoms is probably not a sensible thing to do. We do use injection of contrast, a CT coronary angiogram, to really outline those arteries if patients have, and that's completely appropriate in that space. But calcium scoring for the patients who have no symptoms is exactly what we should be doing. It's simple, it's cheap, it's an incredibly powerful negative predictor. There's about 30 odd years of research backing that up. Remember though, you have to take that calcium score in context of what's going on. So if the patient's calcium score, but they're smoking, hypertension, pre-diabetics, with really bad cholesterol levels, you can't put on that. You would still treat those other risk factors.
Yes, that does completely. But I think this is another important question I wanted to just ask you, Dr. Warwick, is okay, now we spoke about 0. What is the number in the calcium score that often becomes a worry thing for the patient or the doctor or the cardiologist? Or is that also just again, we have to reassess that further?
Yeah, look, it's a great question. And remember, every time I evaluate someone in this context, I look at the calcium score, but I look at their traditional risk factors as well, because you have to marry those up. It's not just the heart, it's the whole person. It's not the engine, it's the car and how someone drives it and looks after it. So we've got to pull it all together. The research would tell us that once you hit 100, a calcium score of 100, then we consider that's a level that's high enough to treat, and plus or minus aspirin is reasonable. We'll see that in the National Heart Foundation guide. A score of 400 is considered high risk. A score of 1,000 is considered very high risk. But it's important to also bring into evaluation of calcium the thing that we call a calcium score percentile. And a calcium score percentile, a comparison for that individual, male or female, with 100 like individuals and get a sense of where they are or where they compare. So imagine we did your score, imagine it was 100, 100's, enough to treat, but if we compared that to other female patients of your age, that would be at the higher end. You'd have a calcium score percentile, and we know that that percentile reflects propensity in the future, and that would inform me to want to bring intensity of therapy to your care. Even though your score's perhaps only 100, if your calcium score percentile's over 90 or approaching 100, so we know you're really at the high end of feeding in your arteries, I would be driving a much harder therapeutic regime. London to a Brit, you would, in that situation, probably have a strong family history supporting those findings, and it would really validate treating aggressively. I don't like, but treating with a high degree of intensity to really get those risks under control.
Oh, thank you. That's very informative because patients often, I think, want to understand where is their risk. And like I said, it's one of those tests that they can self permit themselves, and having those numbers are really helpful. Another question that came up to me, Dr. Warwick, is LDL cholesterol. And we know LDL can have small and fluffy, and there is different types that's predicting the risk and the risk with lipoprotein A. What's your view on when we get someone with high LDL? Is it often necessary to do a subfraction before we treat? What's your experience in that arena?
Yeah, so the subfractions are really research tools at the moment. I get lots of patients who have spent time on the internet getting information that they can to inform their own decisions, which I think, in fact, I'm speaking with you because you probably know I create a lot of content because I love patients to be informed. The problem is a lot of that information is not contextualized and doesn't really doesn't allow patients to get a practical handle on exactly what's going on. The particle size story is interesting, but when we look at it in detail and from a practical perspective, those particles can be considered in context of the fenestra, or the holes in the lining of the arteries that allow the LDL particles to pass through. So if we think about those fenestra, those holes, and for example, imagine that for reference, are the size of a basketball ring, then a large fluffy LDL is about the size of a basketball. So the free, you can toss it in. The small, dense LDLs are the size of a volleyball. Now here, both of them go through the hoop. Both go through the hoop. So if you've got lots of LDLs of the size, it can go through the hoop. And then the question is, for you, do the other factors mean that you've got a great propensity to put LDL in your arteries or not? And that's where sometimes we see people with high LDL, they don't tend to put cholesterol in their arteries. People with low cholesterol, they can put LDL in their arteries. This is where the individual variance and precision medicine comes into play. In terms of measures, I don't bother, actually, Dr. Ashwani, because once the triglycerides are elevated 1.3 to 1.5 millimoles per liter, have small dense LDL cholesterol particles present. If we keep that triglyceride level down, i.e. keeping the insulin levels down, then we're keeping large fluffy particles. And of course we prefer that. We prefer that. Probably related more to the inflammatory processes of hyperinsulinemia, probably more than the LDL particle size.
Thank you. I think that's a very good information because that's, people often think, oh, I just don't want to base it on LDL, but I think we need to look at it at the whole picture and look at where their risk is. Now, another interesting question, Dr. Warwick, I got is, can this plaque formation, once it's formed, what can we do to reverse it? Have you ever seen it being reversed from a cardiologist's point?
And this is a fantastically useful question. And when I'm speaking with my patients about what I'm putting them on a cholesterol lowering medication, I raise this. I mean, because in the ideal world, we would like to see their arteries get better with time. Well, we have had two fairly in the last 3 to 4 years, which have informed us without question that if we get LDL cholesterol down somewhere around 1.5 millimoles per litre, that's LDL down to 1.5 litre, then we have demonstrated in 2/3 of patients going through these sort of trials plaque regression. People 1.5 millimoles per litre or less, plaque regression, and this is the holy grail of our therapy. If we find high-risk people reduce their cholesterol plaque volume, once we start therapy, that cholesterol plaque volume becomes stabilized, and part of the process of it is it becomes calcified. So there is a funny twist there that we can see more calcium. So we don't use, once we decide to, someone doesn't really help us, but we see more calcium. The reason being that we've fatty, unstable, potentially inflammatory, potentially able, we've taken that away and replaced it by this, if you like, fairly relatively stable calcium plaque. So it is the holy grail of therapy, I believe.
So that's, we have heard it from the cardiologist. It does help, and there's evidence behind it. Another question, Dr. Warwick, is now patients sometimes they're like, I've done all my research. I don't want statin. Of course, we speak about ezetimibe to some of them, but there is a new research now. There's an injection coming out for cholesterol management. Are you able to shed some light on that?
Actually, Dr. Ashwani, there are a number of different therapies in the pipeline, and I just realised you also flagged LP(a), and I didn't answer that. I got stuck on the small, dense and large fluffies. I'll come back to LP(a) because it is part of this answer. The most important thing that I try and get across to people when they're wanting to really support patients being educated. The best educated patients get the best healthcare. That is my motto. And I have 200 podcasts. I've got endless courses, books, videos to support people with good information. And when we get onto this, I don't want to take, I direct people to getting information about imaging their arteries. Let's deal with what's actually going on. Let's not deal with a number. Let's just not deal with the laboratory test. And sometimes I'll send people along to virtualheartcheck.au and say, look, just do that, organise yourself a scan and we can go from there. That's a very simple process. You can do that just at home, virtualheartcheck.au. Once we've sort of established what's going on there, we really can then make a call about based on what's in the arteries. And as you said, statins have for 2 to 3 decades formed the foundation of care, and that's because the damn things are cheap and they're effective. So why wouldn't we use them as a first line? But quite right, we're seeing a lot of dynamic change in the space of cholesterol management, and there's a protein called PCSK9. It's something like protein convertase substituency kinase number 9. Don't need to even remember the detail of it. The importance of this little protein is beside the LDL, the cholesterol receptor on the liver. Sit right beside it. And if that protein is into the liver with an LDL particle, then it breaks up particle and it breaks up the LDL. If we can block that little PCSK9 protein, if we put something on that or take it out of the equation, then when LDL, the cholesterol, is taken into the liver by the receptor, the LDL is broken up, stays intact and goes back up to the surface of the liver. the body keeps more receptors on the liver surface ready to take LDL from the bloodstream. These PCSK9 inhibitors, and they work by what's called a monoclonal antibody. That simply means that they've designed an would form against the common cold, an antibody that targets that particular protein. These work incredibly effectively. We see 60% lowering of LDL cholesterol. We also see lowering of around 30 to 40% of LP little a. So these are staggeringly effective, to be extremely well tolerated, but at the moment expensive, and so quite reasonably the government allocate them to people with the hereditary condition of familial hypercholesterol, so very high cholesterol levels, and limit it to people who have got very bad coronary arteries, other appropriate therapy, but are still having problems. These agents are probably in the order of $10,000 per annum.
Wow. But at least we know there are other things that's coming up and you know what can be done. I think we have got, okay, you wanted to come back to lipoprotein A, sorry.
Yeah. What I was going to say is that the PCSK9 inhibitors, they're currently a monoclonal antibody. What the research is driving at the moment is an interfering mRNA. So we can literally look to introduce an interfering mRNA in individual's liver cells, and that means that the individual won't produce PCSK9. So imagine a bit like the COVID vaccine, which is an vaccine, so we're all familiar with that terminology these days. We're now on the verge of seeing a PCSK mRNA therapeutic, which means it'll go in, muck up the body's own ability to make PCSK9, so you don't need to block it any other way. The body will just stop producing it, and that will looks like it will have an equal effect to the current monoclonal antibodies. Now, if you realize that that'll probably last for 6 months, you'll literally get to the pharmacy, roll up your sleeve and get a jab. You will be immunized, if you like, against
Vaccinated against heart disease. Is that right?
Isn't that amazing? Immunized against heart disease.
Yeah.
Incomprehensible. Now, it turns out that mRNA technology is being used for an LP little a target as well. So lipoprotein little a, I don't know if people know what that is. I'll quickly explain it because you've asked. Lipoprotein little a is an LDL particle, so it's part of the lipoproteins of carriers that go around the body. But LP little a is if you like, an LDL particle, the tail on it, and that little tail gives rise to a greater ability to stick within the tissues. So we toss in LDL particles into hoops, into fenestra. The LP little a is more likely to stick, it's more likely to drive inflammation, and it's more likely potentially to drive thrombosis. We see it increase propensity in people have heart disease, but also premature calcification of their aorta. The next 5 to 10 years, we'll see us with LP little a therapeutically. Right at the moment, I'm part of a working party who have put together a document as a guidance document for Australia on LP little a. I'm very proud to be part of that, and it's currently being put in for submission to Heart, Lung and Circulation. If you're curious, keep an eye out.
Wow, that's amazing information. Okay, I think we have come to the end of it. We had a lot of information. Now, before we go, Dr. Warwick, what is your takeaway for our listeners today? What do you want people to know about what they need to do to care for their heart?
Dr. Ashwani, I think the biggest gap is people's lack of the ability to take a picture of the coronary arteries and actually see what's going on. I would love people to be aware that you can look at your arteries. going on. I mean, we take it for granted that we cancer screening test at 50 years of age. We take it for granted that we get our car regularly so it doesn't break down. We take it for granted that women have mammograms and pap smears. Coronary artery disease kills more people than anything else, and yet we actively get ahead of it. I would love people to know opportunity to image. If they wish, they could go to virtualheartcheck.au, where we run a risk score, and if appropriate, help people book a scan without even the need to see a GP or a specialist in any major centre in Australia. That's virtualheartcheck.au. It's sort of simple, it's a few $100, very easy to do. But I think once we know what's going on with someone's arteries, if we find a problem, we can save a life. If we find nothing, a zero calcium score as you were talking about before, that's fantastic. We can reassure those people and see them again in 5 years.
Thank you. I think that's fantastic information, and I think actually the CT calcium score is a very underutilized testing. I mean, I use quite a bit for my high risk patients, but I think that's really important that people can go out and ask their doctor, and let's have the discussion. When do I get it done, and what's the benefit? Be informed about it.
Dr. Ashwani, we put together, literally, I put together a website, virtualheartcheck.au, to allow people to do that and be proactive. Don't even need to see their GP. Your bowel cancer screening kit, it just turned up in the post at 50. You should be thinking along the same lines for men at 50, women at 60, unless there's some other driving answer, like a bad family history or race, which would maybe make us think of doing that testing earlier. I think it will, without question, become standard, but there's a gap between what we can be doing and should be doing and what's currently being done. And I think virtualheartcheck.au allows people to start that process. Own experience, part of the reason for forming that website is that some GPs are not like you. They don't have much of an understanding of calcium scoring, and they will say, oh, look, you're intermediate risk, you should be fine. Reassure I did back in 2003 to the of failing to get the appropriate assessment.
Yes, totally. I mean, I think they need to find someone who's, works with them and informed about them. Now, before we let you go, this is my favorite questions. Is there any books or anything you've listened to that's really inspired you that you'd like to share with us?
Listened to a number of books in recent times. Life Force is interesting. It's pretty dense in terms of information. I listened to Asprey, who written Superhuman and has also written a bit about fasting. I've listened to John Jaquish, Waste of Time, but the top books out there are Atrial Fibrillation Explained, Cardiac Failure, Know Your Real Risk of Heart Attack, and soon Cardiac Rehabilitation Explained by Dr. Warwick Bishop.
Thank you. So we'll keep that in mind and we'll look out for that. So I think it was a real pleasure speaking to you today. I mean, we learned a lot. I think these are information I wanted, because this is not something patients are aware of, testing and benefit of statins and how to look at overall risk factors. And I think you've broken and given us a very good information. So thanks for coming and speaking to us today.
It is a pleasure, Dr. Take home the message: a picture paints that. The picture of your heart arteries, if they're clear, nice reassurance. If there's a problem, chance to do something about it. Check out virtualheartcheck.au and go through the process.
Thank you.
Thank you.
Okay. Oh, good. Wow, that was amazing. Dr. Warwick, I'd like to speak to, actually, I wanted to ask you about lifestyle, but we didn't have much time about fasting and supplements, but maybe we could keep that for another time.
I find it's a good thing.
Okay.
Supplements, I don't know the answer to that at the moment. It's complicated, and I think supplements is probably something that should vary depending on where we are.
And what people need, and yeah.
Yeah. I think to be a really important question is blood pressure. People treat blood pressure, and it's easy as anything to fix. It's easy to investigate.